Hi, I'm Joe Rogers, President and CEO of the Texas Heart Institute, and I'm joined this afternoon by Dr. Carolyn Lamb, who has just given grand rounds at THI, giving us a great perspective on the history, the present status, and the future of heart failure with preserved ejection fraction. Carolyn, thanks so much for joining us at Texas Heart.
Thanks so much for having me.
Listen, I wanted to just take a few minutes to explore a couple of topics that you brought up. And a lot of times we use this particular segment to try to take what was brought up in grand rounds and make it practical for the practicing clinician.
Great.
And so one of the things I'm interested in is your perspectives on how we should be clinically phenotyping patients who have heart failure and their ejection fractions are, you sort of said above 40, above 50, but people who have preserved ejection fraction. From a clinical perspective, what is your recommendation to the practicing clinician?
You know what, Dr. Rogers, could I even step back and say what would be the approach to heart failure diagnosis and treatment in general now? Because I do think that the data that SGLT2 inhibitors work across the entire spectrum of ejection fraction is going to change the way we think about how to approach these patients. So I think that the first thing is to go by symptoms and signs to make sure we recognize the clinical syndrome of heart failure. And then if we're sure of that, you can already treat without knowing the ejection fraction. Seriously, we can already treat the congestive state with the diuretics. If there's no contraindications, start the SGLT2 inhibitors. Even while we're waiting for that echo or whatever confirmatory test we need to subphenotype the patient. So start that treatment first, treat the precipitants, for example, for goodness sakes, if that patient has a runaway arrhythmia or if they're having ischemia, let's treat that. Then the ejection fraction comes back. If there's any evidence that there is left ventricular contractile dysfunction, with just an ejection fraction that's not normal, then start neurohormonal blockade. If it is not, now that's the tricky bit. I do think that now that we have specific treatments for some types of specific diseases like cardiac amyloidosis, that's of course with tafamidis, obstructive hypertrophic cardiomyopathy with mavacamten, it behooves us to identify those treatable mimickers. So that's the next step. And then, of course, is to control their comorbidities. Does that make sense?
Yeah, no, yeah. I think so. It's just interesting because there are so many drivers of the phenotype. And sometimes today I think we're kind of in the lumping phase. We're assuming that all of those phenotypes are gonna respond to the same treatments. And I guess I wonder from your perspective as this thought and as our knowledge of the biology moves forward, will we be using our therapies in different ways in these different kinds of clinical phenotypes?
Yes, yeah. I really think so. And so I'll give a concrete example. Although we're waiting for the trials, I think that identifying the patients with a predominant inflammatory response, and that could be with a biomarker like CRP, for example, we could be actually giving specific anti-inflammatory agents in the future. We should also very much pay attention to comorbidities. For example, if a patient with HFpEF has diabetes, please treat with SGLT2 inhibitors even while you're waiting for approval of the SGLT2 inhibitors for HFpEF or for the guidelines to catch up. I do think in those simple ways, we are phenotyping and adjusting treatment accordingly.
Now your talk was interesting because you really didn't comment much on the MRAs. And I want to know how you integrate the use of spironolactone in your treatment of this patient population.
You caught that. So, this is one that I struggle with. And that's, by the way, the big difference between the European and the American guidelines. So, the American guidelines, based on the TopCat results in the Americas, does recommend consideration of spironolactone, right? Notice that the European guidelines, that's where it differs, doesn't. I tend towards TopCat was a neutral trial. And you may say that the results are positive in the Americas, but I'm in Asia. So what does that mean to me? So what I do practically is use any excuse to use spironolactone, not based on the guidelines in my region, but for a potassium sparing effect. Because these patients need diuresis anyway. So if their potassium goes a little bit low, instead of giving potassium supplementation, I add spironolactone. For blood pressure control, spironolactone is a great antihypertensive. So I use that a lot. So I kind of use those reasons, hoping that the ongoing trials will show that it is a positive, like the SPIRIT trials and so on, they're retesting the whole TopCat thing.
Yeah, I think the hypothesis needs to be retested.
Yeah.
I think the thing that was so striking to me about that analysis of the geographic variation in response to spironolactone was that the mortality rate was so much lower in Eastern Europe, which made me ask the question, did those patients really even have HFpEF? Do they? And I don't know what your interpretation of that was, but I guess the way I've been practicing is if I really believe that my patient has the clinical characteristics that fit the trial profile in North America, I've been using the drug.
Yeah.
So
very, very reasonable, I think. And then, of course, just make sure that we monitor them for adverse events and all that. I would also add that beyond questioning if those patients that were recruited in Russia and so on had HFpEF. Remember that was an analysis of the spironolactone metabolites that was published in the New England Journal as well that showed those randomized to the active may not have even received the drug. So I think there's grounds to question, but I'm in Asia, so what do I do?
Right.
So I think I keep that in mind and look forward to further evidence.
I want to explore one more thing before we conclude, and that is, you created a really interesting and compelling story around adiposity, and it's obviously an important issue for us in the United States as it is across the world. Do you think that managing adiposity is going to be a target for the management of HFpEF?
Yes, I do. In all of HFpEF, no. In obesity-related HFpEF, I say that very carefully because some obese individuals may have HFpEF for other reasons too, but in the real obesity-related HFpEF, I do think that it's the excess fat and body weight that's contributing to the manifestation of the syndrome, and so targeting it is going to help. But we'll soon have the data from ongoing trials. It's very, very exciting. I want to make it very clear though, I strongly believe that targeting obesity can prevent HFpEF. So prevent new HFpEF, I'm convinced.
Well, that's great. I think this has been a wonderful hour and a half, just being able to stop and think about this complicated disease and listening to your story about how it's really evolved over the last 20 years. Thank you again so much for visiting us at Texas Heart Institute.
No, thank you, Joe, for all that you do, you and your team. You know that, and I was hoping you'd ask me a little bit about sex-specific approaches and how important it is to recognize that there are fundamental differences in cardiac physiology and structure between women and men. And so I just really want to salute you for leading an institute that does focus on that.
Thank you.
And I think that's also a very important area.
Well, we'd love to have you back so that we can explore that further.
I would love to be back. Thank
Thanks,
you.
Carolyn.